This conference will now be recorded.
Okay, welcome to the Gynae EMQ session. Let us start. So, here the patient present to us in the gynecology emergency unit suggestive of ectopic pregnancy. Single most useful investigation that you would recommend. Patient has abdominal pain. Scan suspected of interstitial pregnancy. Diagnosis is uncertain. Beta HCG is 3000.
Mm,
So they are not sure of diagnosis. It is an interstitial pregnancy. So
no, MRI.
yes, MRI to confirm the diagnosis. So this is your guideline. How the interstitial pregnancy diagnosed. It has to be sonography, and if it diagnosis is like uncertain, then supplementation with MRI can also be helpful in diagnosis of interstitial pregnancy. So, 28-year-old woman suggestive of ectopic pregnancy. This is confirmed series of investigation, and the USG shows a nexa mass of 30 mm, no pole, and with a yolk sac. She wants medical management.
Option I.
But before you give methotrexate, you need one more investigation.
Beta
How?
HCG.
Yes, you have to
Beta
do.
HCG now.
You have to do beta CG now. Depend because you need a baseline beta CG. Depend on those, you can do further monitoring. So, 26-year-old woman with unruptured ectopic. She fulfills the medical management criteria and IM methotrexate given.
Now option I.
Yes, no option I. So the student has had a methotrexate in management for ectopic pregnancy during counseling. She want to know uh, during treatment will point to the higher chance of diagnosis, higher chance of success. So she wants to know that how she will get to know that the success would be there.
Option G.
Uh, H. You have to do when you will do the beta CG on fourth day. That time, uh, no option. It should be G. Basically G. On day four, next beta CG. But you have to compare. So yeah, it should be ideally G. So 27-year-old woman with painful ulcers around anus and vulva. These are quickly ulcerated. These are associated with swelling and pain of groin with no discharge. These are soon followed by swelling in groin, multiple anogenital ulcers, and features of lymphadenitis. So, what is the cause of ulceration?
Genital herpes.
Herpes.
Both painful, ulcers painful, growing painful. Like
So, painful ulcers And in usually in herpes, patient will have a micturition problem also, and they have features of lymphadenitis and swelling in groin. It is chancroid. So painful there should be anogenital ulceration, lymphadenitis, progression to bulbo formation, and ulcers will have an undermined edge, yellow gray base that bleeds. They may be painful, they are single and multiple. Painful inguinal lymphadenopathy may be there. Okay. So it is there is they have not said anything with a micturition or something. And features of ulcers and the lymphadenitis is there. Okay. So it is Shankaroid. So multiple ulcers, day 4. Ulcers followed by painful blisters. Rupture of blisters. 9 years ago, she has LMP, combined COC. She has got superficial tiny ulcers, erythematous halo, and yellow base. Bilateral bilateral uh, inguinal lymphadenopathy. So herpes, usually the flu-like symptoms, tingling, itching sensation, bilateral inguinal lymphadenopathy, painful ulcers, usually bilateral. Okay, so bilateral inguinal lymphadenopathy and like erythematous ulcer, yellow base ulcer. So this is suggestive of herpes. But ideally, when the herpes question come, they also write painful micturition. But here in this question, it is not there. So woman presented with a widespread rash of 3 week. She has a fever, rash, bone pains. On questioning, she has similar rash on vulva a few days back. Resolved without treatment. Examination shows maculopapular rash on face, hand, palm and sole, yeah, hand and sole of the feet, as well as on the vulva and anus.
Secondary syphilis.
Yes, yes, it is secondary syphilis. Maculopapular rash after uh, one episode that get corrected by itself. It is secondary syphilis. Okay, 40-year-old woman with the ulcers. Not itchy, no vaginal discharge. There are whitish, flat-topped nodules. Nodules are thick and not ulcerated. Flat-topped purple nodules on wrist. So keyword is flat and purple. So flat purple is lichen planus. Usually they are purple pink, flat topped, lacy white lines. That is called as a vegan stria. There could will be loss of anatomy, erosive lesion, and they can turn into squamous cell cancer. 3% of the cases. So now here, like the patient came with a vaginal bleeding, with or without endometrial biopsy. Choose other option with a single management option. 38-year-old woman with PCOS, counseling for periods. She indicated that there is a irregular period is always irregular. She took clomiphene cited for 2 children, last of which 8 years ago. She menstruates three times in a year. Last year period was 6 months back. ET6, no other abnormality. It is 6. She has no period 6 months.
Mm. Mm. P. Progestogens for withdrawal bleeding.
Why I wrote L. So P is also correct, progesterone or I wrote medroxyprogesterone acetate cyclical. But yeah, your guideline answer, if will go, then it will be gestrogens. So P should be the answer. But P or L almost same. So this is from the guideline that every 3 to 2 months they should have withdrawal bleed and they should be treated with gestrogens. So 40-year-old woman with PCOS, amenorrhea of 9 months, her ET is 8 mm. No other abnormalities on uterus.
Um, Interventional biopsy.
Yes, biopsy. So thickened endometrium till 7 there is no problem. If it is more than 7 or
Mm.
endometrial polyp, consideration for endometrial biopsy or hysteroscopy. So 43-year-old woman has an endometrial thickness of 9 mm. She is reported to have hyperplasia with atypia.
Mm. So, Um, PHBSO.
Yes. So the she's like THBSO should be the answer. But on the other side, if you see that she's a young woman of 43, so plus minus ovary diagnosis to be there, and ideally it has to be done by laparoscopy, but that option is not there. So 50-year-old woman, she is report 6 months. She irregular bleeding last 4 years of duration. She reported 6 month has been amenorrheic. You examined and you find 12 weeks uterus, suggestive of uterine fibroids. You arrange for ultrasound, which shows that it is 10 mm. Endometrial biopsies are arranged, and that reveals hyperplasia with atypia.
Ma'am, THBSO.
Yes.
T.
Women with atypical hyperplasia should go total hysterectomy because of the risk of underlying malignancy or progression to cancer. So the patient complains of micturition, painful micturition, frequency nocturia, urgent incontinence. You suspect possibly bladder pain syndrome. Urine analysis is performed is negative. So
L.
I'm initially so urodynamics is not that easy investigation.
No, ma'am, L. Urine for urea plasma chlamydia.
Urine analysis is negative. The question we have done previously, the urine infection was reported, but the culture was negative. But here, urine analysis is negative.
Mm.
So you are not sure what you will do. You will give that bladder diary.
Oh.
So first will be bladder diary because they are confused in the diagnosis of BPS or urgent incontinence. She has faced urgent incontinence. So you want to give her bladder diary. So there would be review of symptoms that will help in reaching the diagnosis. Okay. So when all series of investigations are done, then the urodynamics will come, but it will come at the end.
Hmm.
The patient come to the clinic with urinary symptom, lower bladder pain of 10-month duration with dyspareunia, diagnosis of bladder pain symptom, suspicion. There is suspicion that she can't empty her bladder fully. So what you will do?
Estimation estimation of residual volume,
Or yes, that is
bladder scan.
yes, bladder scan after maturation. Same thing. Post void residual PVR scan. Okay, 65-year-old woman with the features of painful bladder syndrome. Urine analysis shows red blood cell 3 plus, leukocyte 2 plus. Urine culture is negative, but microscopic hematuria persisted. It is hematuria is there. What you will do?
G.
Yes, very
Urine
nice.
for cytology enzymes.
First, you will do cytology. After that, you will do a cystoscopy. 33-year-old woman with painful bladder syndrome. Increased frequency of maturation last 12 months. Diagnosis of BPS has been made. Urine analysis result negative. Uncertain about functional bladder capacity. Now we don't know how much is the capacity.
The urodynamics.
So ideally, it has to be urodynamics. And 39-year-old woman with two. Now here the patient is diagnosed with the ovarian cyst. 39-year-old woman with 2 weeks of duration, pain. Pain is initially mild, not require any analgesia, now had disappeared. She is a mother of two children, healthy. GP requested scan and the cyst shows 42 to 48 diameter.
Follow up with serial ultrasound scan. B.
It is less than 5 centimeter.
Huh.
Less than 5 centimeter,
And
what do you do? Nothing. Simple cyst, less than 5 centimeter, nothing to be done. So reassure and discharge. So 35-year-old woman has an axil mass of 5 to 6 centimeter complex cyst. So what you will do? Complex cyst is there. Periods are irregular.
yearly ultrasound scan.
Scan after 1 year. That will happen according to the guideline when the simple cyst is 50 to 70 centimeter. That is for simple cyst. Here it is complex ovarian cyst, and the patient has symptoms of irregular bleeding. It could be what? Germ cell tumor, young age. So answer
Then we will have the tumor markers.
yes. So answer you have to do LDH, alpha fetoprotein, and beta HCG. So here 45-year-old woman, scan shows left ovarian cyst 16 to 6 centimeter, no fluid, CA125 is 150. So what you will do? C125 is high, more. Answer is
So,
MRI. So simple cyst of 50 to 70 centimeter, yearly ultrasound follow-up, and those with larger cyst, larger simple cyst consider either MRI or surgical intervention. They have not specified, whether it is it is a simple cyst, but as a C125 is also high, so before you do anything, you have to consider doing MRI. Okay, clear?
Mm. Yes.
So here the 42-year-old woman with a vague abdominal discomfort. Scan shows no, it is 70 centimeter complex cyst. CA 125 250.
Laparoscopy salpingo-oophorectomy.
Salpingo-oophorectomy.
Complex is CA 125 250.
So it is if the feature suggestive of ovarian malignancy and CA 125 more than 200 or evidence, then referral to gynaecologist. So here it is a complex cyst. CA 125 high. Patient has got discomfort. Okay. CA 125 more than 200 and the patient having symptom. So refer to gynecology. Opinion from gynecologist has to be taken. Okay, gynecologist opinion. Oh God, these are a little difficult questions about the type of study. Now, 158-year woman, 20 to 29, who presented in 1996 2001 with irregular bleeding with PCOS, made in community referred to the gynecologist. So, what kind of study?
Cross-sectional.
Why?
Over a period of time.
But it is back to 96 and to
Oh,
2001. So, it is retro.
I didn't notice.
Active studies. These studies look the
Mm.
past to know who developed disease. Okay.
Mm-hmm.
So a combination of 14 observational studies published in now they are combining 14 studies to find out efficacy of intramuscular progesterone uh, for preterm labor and prolonging pregnancy. So what is it? They are combining the effect of
Meta
mm, uh,
meta-analysis.
yes, it is meta-analysis. If the many studies have been done on the same topic, then the sum effect of all studies has to be calculated by meta-analysis. Very nice. So a combination of 8 trials. Now here trials are going on to assist effect of danazol and GnRH in the symptomatic endometriosis.
Systematic review.
Yes, it is systematic review because they are doing RCTs. So 8 RCTs they are combining. So they are doing systemic review. So attempts to collate evidence from relatively smaller number of studies pertaining to found research question. Here 8 trials has been done, so it is systematic review. Now 571 women divided into two groups to find out the effectiveness of LNG and effectiveness of medical treatment.
Mm.
So there are two groups. There are two arms are there.
O. O. Randomized double-blinded study.
This is RCT. They have not, the question doesn't say anything about the blending or non-blending. So we'll not speak that. So it is RCT.
Hmm.
26-year-old woman on CS on hormonal contraceptive taking 20 microgram of estrogen and 150 norgestrone. After 2 months, she presented to her with the unscheduled bleeding. So it is less. See, till the 3 months, they don't change the HRT. Young woman,
Hmm.
6 year possibility of STD is there. So you have to kind of make it sure that she has no STD. After, if she has no STD, then she would wait and watch till 1 month more. Okay, and
Okay.
this is the flow chart. If the problematic bleeding is there less than 3 months, need to rule out STD, need to rule out pregnancy, cervical pathology. If all three are excluded, then the patient has to be reassured. So young woman, 26 years, STD, you have to rule out. Now the patient is on patch for 3 months ago. She has never had smear, complaining of bleeding. Since same relationship 5 years, no suspicion that partner is unfaithful.
R. Speculum examination cervical screening.
Yes, because you don't know what is happening to the cervix. Again, if the patient comes with a problematic bleeding, the take clinical history, how she is taking pill, then check for STD, look for cervical screening history, and check for pregnancy test. So gynecology examination or perspective. So patient is started on 30 microgram of estrogen pill, unscheduled bleeding 4 month duration. Last cervical 2 year ago. GP referring to GP said no pregnancy and improper use. So what you will do? She's having bleeding till after 3 months also. No pregnancy, no cervical cause.
Then then you can increase the dose. Option F.
Yes, option F. And this is the answer. If the patient using COC lowest dose to like to provide good cycle control, but dose of estrogen can be increased to 35 to provide good cycle control. Most common side effects: patient on long term treatment for heavy periods, she is having irregular vaginal bleed, blast tenderness, acne, and headache. Who has these side effects? Acne, headache, breast tenderness.
No. Combined. Like oral progestogens. G.
LNGIUS. Progesterone, oral progesterone usually has fluid retention symptoms, bloating, headache, acne, and breast tenderness. These are classical symptoms of LNGIUS. Even you will see in your practice that patient develops such a headache and breast tenderness, and for this reason, LNGIUS has to be removed. Okay, it causes so bad headache and breast tenderness. So the patient was put on treatment. Now she complains of diarrhea and indigestion. Who will have gastric side effects?
NSAIDs.
NSAIDs. Now the patient has breast tenderness, nausea, headache, fluid retention, mood changes.
Oral progesterone.
Uh, Oral progesterone. CHC is the answer.
Mood changes also.
Mood changes, yeah, caused by CHC. She's having breast tenderness, nausea, headache, fluid retention. CHC. Irregular bleeding, weight gain, premenstrual symptoms like breast tenderness, fluid retention, and bloating.
Irregular vaginal bleeding is progesterone.
Yes. This is increased weight gain also.
Yes,
Weight
ma'am.
gain.
हाँ
DM,
हाँ
MPA causes 5% of weight.
Indian.
So here emergency contraception. 26-year-old woman, 80 kg. She is having asymptomatic chlamydia infection. What good EC for her?
Copper T.
Copper T by? Though she's having asymptomatic infection. So avoid
More than 70 kg. More than 70 kg, we can't give Ilipristal.
more. No, no. You can give Ulipristal has got no problem with the weight. LNG has, if the weight is more than 70 kg, you have to give double dose. Ulipristal acetate can be given. Ulipristal acetate cannot be given if the patient has any contraindication, or if the patient is having this, like if patient is on enzyme inducer. Okay.
Okay.
So 26-year-old woman, 30-day cycle. She comes for emergency contraception 18th day of cycle. So what can be given?
And then it's after ovulation, so we'll give copper T.
Yes, copper T. Copper coil can be given till 19th day of cycle. So yeah. So copper IUCD, it can be given 5 days after earliest date of ovulation till 19th day. LNG within 3 days. UPA 120, 5 days. Double dose of LNG recommended woman taking enzyme inducer. Double dose of LNG if the patient has a BMI of more than 26 or more than 70. So for ulipristal acetate, weight is not an issue. 30-year-old woman suffers from epilepsy taking carbamazepine. What EC?
Uh, copper T or
Yes,
neither double T.
copper T because it is not affected by enzyme inducer.
Hmm.
Patient with on rifampicin or tuberculosis. What single episode? 24-hour single episode of unprotected sex.
Dou- Double dose LNG.
Either double dose LNG or copper T is the best, if she agrees.
Ma'am, if both the options are given, what to choose?
See, basically, the questions that we are doing is incomplete. But if they ask you the best option, then it will be copper T. If they ask you oral treatment, then you can consider giving either double dose LNG or ulipristal. They will
Ma'am, because here 24 hours has been specifically mentioned.
24 hours makes no sense. Copper T can be all three can be given within 24 hours.
Mm-hmm. Okay.
In the exam, you will get a better, specified scenario with the details. Now this is okay. So 24-year-old ST1 uh, attend her ARCP logbook reviewed. She has good achieved progress and development of competency what they want. So what is ARCP outcome? So she is doing Y.
A.
Yes. So if evidence provided at ARCP satisfactory, then the panel will recommend ARC outcome 1. Student attend ARCP, they conclude that there is specific competency is required, but not training. So they want her to develop specific competencies.
B. Outcome 2.
Yes. So if any deficiency in training or areas of poor performance, panel will recommend outcome 2 or ARCP2. Very nice. So patient on 6th year of specialty training passed part 3 and told that evidence submitted is incomplete, like paper additional training time is required.
5. E.
Hmm? Yes, 5.
5.
It's a submission, so additional training. Outcome 5 may be recommended as a consequence to submit form R. ARCP review panel concludes that he is completed training program and he is moved forward with the CCT.
6. Outcome 6. F.
Yes, outcome 6. So they can proceed. So, 30-year-old student, inadequate diagnosis, inadequate progress, additional training time required.
Outcome 3. C.
Outcome 3, very nice. And if the deanery says that released from training program,
4. Outcome 4. D.
yes. If any training get outcome 4, they had to leave their training. This is ARCP outcome 1. Then they can proceed to next year. This is outcome 2, where targeted training is required. This is outcome 3, where additional period of training is required. Outcome 4, released from the training program. Outcome 5, paperwork is not done. Outcomes final ARCP or 6, they will be promoted to CCT. Okay, so 45-year-old woman with urinary incontinence on coughing and routine exercises. She supervised exercise done by GP under supervision 6 months failed to reduce her symptoms. She referred to output department. Urodynamic testing ordered as an assessment. These features shows consistent USI. So she has got USI. Treatment.
We'll move forward with surgery. Mm,
Call for suspension.
Um, Colposis.
Previously, it was TVT. So in the book, you will find TVT as the answer. But as the mesh has been removed, so answer becomes suspension. So a 79-year-old woman, troublesome urinary incontinence, repeated infection, urgent continence, nocturnal enuresis. She is having suprapubic mass, that is bladder. Urodynamics confirms that she is not able to empty her bladder. She is not fit for surgery and fit enough to live at her own. So she has a mass and the bladder cannot be emptied by herself. She is fit.
Mm, um, Intermittent self-catheterization.
Yes. Offer urethral catheterization, women with urinary retention who can be taught self catheterize or carer can perform that. So 80-year-old woman, urinary incontinence, urgency incontinency nocturia. She has been seen clinic few months back. Chronic urinary retention diagnosed. She requires 24-hour bladder care. She has bad sores. What is the answer?
Indwelling self-catheterization.
So answer is indwelling catheterization. So according to guideline, long-term indwelling catheterization for the women who have retention cannot do self intermittent catheterization, who has got skin wounds, pressure sores or irritation caused by urine, unable to like disruption caused by bad change of clothing. So answer is this. Now the 45-year-old woman, Urogynec clinic, she has been diagnosed with AAB. Now she's on the new drug to control her OAB. So how you will follow her?
D. Telephone review after 4 weeks.
So no, A. So offer face-to-face or telephone review if a medicine of overactive or urinary continence stop working after initial 4 successful week review. So both are there, face-to-face or telephonic. Okay, that's it. Any question?
Mm,
Okay, thank you for joining.